Good afternoon, everyone from London. I hope you can hear me. Thank you for the introduction and to the ESC for their support in facilitating this webinar today. I, of course, have no conflicts of interest to declare that are relevant to this talk. I would like to put things into perspective from the outset. Although COVID-19 has been the overarching healthcare emergency globally, we know that cardiac causes, predominantly in the form of coronary artery disease, is the most common cause of death worldwide. Now, during the pandemic, we have seen a reduction in the number of patients presenting with myocardial infarction, and indeed surveys have suggested that this has been due to a reduction in healthcare seeking behaviors amid lockdown measures. We have also seen the impact of delayed presentations, which has been associated with a significantly higher fatality rate. As lockdown measures are eased globally, we are faced with several challenges from a cardiovascular perspective. Firstly, COVID-19 related complications and mortality are higher amongst individuals with established cardiovascular disease. Therefore, primary and secondary prevention efforts in this cohort will reduce the burden of the current as well as any potential future outbreak. Secondly, the impact on service delivery has been significant. This can be thought of as two parallels. The first being the backlog of elective work, which was put to a halt in the restructure of services. The second parallel being the delivery of our acute services across the breadth of cardiology. We also acknowledge that there is a close interplay between healthcare and politics, perhaps more so in the current era. We must not forget that the pandemic has had a significant impact on our workforce, and they have risen up to the challenge to work in these unprecedented times. Importantly, our patients need to be encouraged and educated to seek medical input without any hesitation. Lastly, of course, there is a fear of the unknown with a novel disease process, as we have been talking about, as well as its epidemiology amid the easing of our lockdown measures. There are several aspects which, addressed well, will help us tackle these challenges and deliver sustainable care. Firstly, we must ensure that we are kept appraised of COVID-19 disease epidemiology on a local and a national level and act in a timely fashion when required. We, of course, have seen exceptional teamwork across various healthcare systems, both in the private and the public sector. We've seen successful hub and spoke models of care being delivered, as well as extra capacity and capability built into our health services. We, of course, must utilize consensus policies and guidance, both from local and national bodies regarding the care of our patients with a focus on infection prevention. Indeed, hospital trusts must anticipate a potential need for PPE in advance to try and ensure that their workforce are kept safe. We must work as teams to ensure that services are delivered on a case-by-case basis and are prioritized based on clinical need at all times. Lastly, we always must remember to abide by an ethical framework during the pandemic, which takes into account maximizing patient benefit, treating individuals fairly, and delivering high-quality, consistent care across the board. Now, societies across the world have produced guidance to help facilitate this transition in care. This is an example from North America, where they have adopted a traffic light system to aid the careful planning, scheduling, and the organization of their care. Level 2 in orange depicts the reintroduction of some services. Level 1 in green here depicts the reintroduction of most services. And level 0 gives the go-ahead to recommence all regular services. Now, such documents must remain updated as we evolve through the pandemic. As has been mentioned already, as a consequence of the COVID-19 pandemic, we have seen the widespread adoption of e-health, which utilizes information technology and communication technology to aid patient care. there has been a particular focus on telemedicine, which has largely been keeping afloat our outpatient clinics. In addition, we have seen the benefit of mHealth, which includes the use of mobile applications from a health surveillance perspective, as well as pHealth, which includes wearable devices such as patch monitors. These have the added benefits of a longer surveillance and a theoretical reduction in risk of infection, as well as reducing the pressure on our resources. We have also witnessed our pacing teams develop successful remote interrogation and remote monitoring systems during the pandemic. There is, of course, no doubt that such technologies, in addition to electronic patient records and, as we've mentioned, AI, are here to stay, and we must continue to embrace their use in clinical practice in a safe fashion. I wish to now briefly talk about a few examples where innovation and the use of e-health during the pandemic has complemented traditional models of care. Firstly, in relation to chronic disease management, colleagues from the Netherlands set up a very simple, user-friendly mobile health program called Tele Check Af. Now, this simply utilizes a smartphone app for patients with AF using their index finger and a phone camera. And the can gauge information about a patient's heart rate and a rhythm and incorporate this into their teleconsultation and monitor an individual's AF management remotely. It has been designed during the pandemic and has now been utilized across 36 centers and counting, and has empowered over 1,000 patients. Importantly, the team involved in this research are also planning to collect outcome data in order to perform a retrospective analysis into the safety and the impact of this approach on patient care during the pandemic. Next, keeping to the theme of chronic disease management as well as prevention, cardiac rehabilitation has traditionally been delivered in hospitals or outpatient clinics, though uptake has been varied globally. It, of course, has a Class 1A recommendation in guidelines with proven efficacy in the reduction of morbidity and mortality for individuals with cardiovascular disease. Now, home-based cardiac rehab is a concept that has been around for a while. Indeed, this slide has been taken from the AHA guidance, which came out last year before the pandemic, and it nicely depicts the interventions that we can involve our patients with, which would lead to targeted behaviors and, in the end, a reduction in secondary prevention outcomes. One can appreciate that telehealth can deliver these interventions as a very viable alternative during and after the COVID-19 pandemic. Some centers indeed have adopted the use of telehealth to deliver their cardiac rehab programs with great success. And there is no doubt that there is an immense role to use this both in the primary and the secondary prevention of cardiovascular disease going forwards. Lastly, in a high-risk group with complex medical needs, such as patients with heart failure, colleagues from Italy have adopted innovative strategies within a few weeks of the pandemic outbreak in Italy. They admitted patients into 3 designated areas, as depicted here in the red, the pink, and the green. And depending on a patient's COVID status, which might have been confirmed, suspected, or excluded, patients were organized in their unit. Indeed, temperature was recorded on average at least 3 times a day, and patients changed between these zones depending on their clinical, radiological, and biochemical testing data. This innovative model of care took into account PPE issues as well as the optimization of their workforce. Indeed, similar models have, of course, been in widespread use across the world in various settings and have demonstrated our rapid innovation and an adoption of working in this new normal. We have touched on cardiovascular research today, and as a specialty, cardiology has been at the forefront of clinical research. This, of course, can now be thought of in terms of COVID and non-COVID cardiovascular research. Amid the pandemic, we are faced with some obstacles, however, especially in terms of patient engagement, recruitment, sticking to timelines, as well as a potential for loss of data. Indeed, the temporal variation in COVID-19 infection globally might also impact upon the demographics of the cohort included in our research studies. one of course must appreciate the regulatory as well as funding constraints going forwards, and these will impact upon existing as well as future trials. Lastly, we must remain astute to the potential for bias in research during this era. We must scrutinize the data, its interpretation, as well as the sources. Indeed, we might witness an impact on the generalizability of many of our studies, and as well as a trial validity. Lastly, there has been phenomenal teamwork and commitment demonstrated by everyone working in healthcare across the board. However, we must not forget the physical and the mental impact of the past few months on their long-standing well-being. The impact on training for doctors and nurses must also not be forgotten, and relevant educational bodies need to address this going forwards. We do also need to pay particular attention to the demographics of individuals working in healthcare, particularly at the front line. My final thoughts are that COVID-19 very much remains an unpredictable infection, and we were clearly inadequately prepared during the first wave in many respects. However, we now potentially have a clearer vision for our patients, healthcare systems, and as individuals. I thank you for listening.
Thank you. I think it was extremely nice, this overview. We have some questions, and I encourage all the people that are listening to all the speakers to send your questions and even share your thoughts. Here we have a question from one of our speakers from Data. The major drawback of telemedicine in caring for cardiac patients is the inability to perform a proper exam. And this is especially true in our patients, specifically cannot listen to the heart, to the lungs. And do you think, are there any technologies on the horizon to facilitate a virtual stethoscope? What do you know about that?
I think that's a great question. And I think the first thing I'd like to say is that telemedicine isn't here to replace how we practice medicine globally. And indeed, the art of medicine is very much engraved in a structured clinical encounter, especially for a new patient, which involves a structured clinical examination. Now, telemedicine can, of course, accompany this. It's not here to replace it. And I would like to stress that. There are, of course, technologies on the horizon, including use of AI, virtual stethoscopes I'm not entirely sure about and how that might be used going forwards. But I would like to very much stress that I don't want us to replace routine clinical care. And perhaps what we need to do is to streamline our patient cohort into whom telemedicine might be very useful for, such as our follow-ups, patients who we have had time to examine, or whom we might have investigations available for. And certainly that's what we've been doing in our practice in London, and it's worked very well.
I have a personal question because I tried to find something in the literature, but I have not seen nothing related to the psychological aspect of potential or high-risk patients, cardiac patients. For example, we had one of our patients with an LVAD. He attempted suicide, disconnecting the batteries and so on. And maybe high-risk patients, we should protect them with this type of crisis. Yeah.
I would completely agree with that. And you alluded to the research. Well, there is some research from America which looked at the home-based cardiac rehabilitation setting, for example. And they've clearly demonstrated that it's a great thing to do in your low to moderate risk patients. But higher risk individuals, you almost need to have a hybrid approach in which you incorporate a physical encounter with a patient. There are, teams who are producing videos for patients that they can use at home to try and assist them to use certain technologies, but certainly the patient that you've described very much would benefit from a physical encounter rather than telemedicine. And that very much goes into the sphere of making sure that these technologies are safe and they can be applied across the board.
What about the legal consequences or the legal issues with telemedicine?
So that's very much something that's been spoken about for many years now, really, in the digital health era. And I think the first thing to say is that speaking specifically about COVID-19, is that we've been engulfed by the pandemic overnight. None of us knew this was coming. Certain individuals might have, but from a healthcare perspective, we very much found ourselves thrown in at the deep end. There, of course, are legality issues around telehealth, particularly, for example, let's talk about consenting for patients. We talk about information sharing, the interface that are being used for telehealth. But we mustn't forget that we have used these technologies during the pandemic to great effect. And I accept that there are some questions around the legality going forward, and I very much welcome them being addressed by the relevant societies. But we must use this almost as a springboard to say that we've used such technologies to good effect, and we can, moving forward, use them even more.
Yeah, and also last question that we have for you, because we need to close in a few minutes.
Sure.
Well, you said that we were not really prepared. Now we know more about the virus, and maybe we are more prepared. But don't you think that the doctors, the nurses, they are now exhausted, and we should consider that for a potential second wave?
Are you talking about the physical consequences of the pandemic on our staff? You're absolutely right. And that's very much what I was alluding to. And I think what we need to do, particularly over the next couple of weeks, as societies nationally and internationally, is we need to think about how are we going to rejuvenate our workforce. Particularly, there's been a restructure of the way doctors and nurses have worked during the hospital in terms of their rotas. We've seen an enormous increase in both capacity and capability built into the system, but it has relied on essentially on human beings providing that. And I think there really does need to be some consideration given to these aspects going forward. One potential solution might be where we look at our staff at trusts as at the local level, and we see how we might be able to rotate staff. Perhaps we speak to them as individuals, we see how they're getting on, we offer potential solutions to them to ensure that they're not neglecting their well-being, because we very much are still in the pandemic.